do that. All right, very good. So this is a lecture that I originally did a few years ago, and it got my current gig as assistant professor. But this is a really important subject. It's obviously something we all deal with in our day-to-day practice, but fighting through stigma and how it affects those that struggle with substance abuse, for us as folks that treat them, society in general, and well, it permeates everything we do. So this is titled "Fight the Good Fight: Combating Stigma and Addiction Treatment." That's me. Disclosures is I have no disclosures. I'm going to keep it that way now and forever. I never want to be accused of, peddling medicines because I own stock in medicine or whatever. I don't. These are my views, and my views alone don't represent anybody else. So what do? I work at WVU, assistant professor now. I run the inpatient dual diagnosis unit, which is kind of crazy, and the outpatient intensive outpatient program, and I help out with y'all sometimes too when they tell me to. In case I slip up and say something I shouldn't, so I get very fired up about advocacy at times. Pardon any profanities. And I found this nice quote from Johnny Carson: "Never use a big word when a little filthy one will do." So that was the most PG rated quote on swearing I could find. I like that one a lot. So that's Johnny Carson. All right, so the objectives today are to define stigma and the domains of stigma. So there's various parts of stigma. So when we talk about it, complain about it, understand, the various areas that we can address. So we'll look at the issues of stigma in addiction treatment. We'll make the case for utilizing effective advocacy. We'll look at two cases that I had when I was in training that kind of still stuck with me and are a good example of, I think, advocacy and how you could maybe intervene and what happened in my case. Look at some examples of advocacy to combat stigma. A little bit of lessons learned from my efforts in advocating, not to say that I'm an expert or anything, but time permitting, there's actually a new U.S. Department of Justice guideline. And this is within the last month and a half. I don't know if anybody's heard about this, but because we don't have a case today, that gives me more time to talk and yabber on. So we're actually going to go over this new U.S. Department of Justice guideline on the Americans with Disability Act and how it affects OUD patients. I don't know if anyone else is aware of this, but it could actually be a game changer in a positive way. So we're going to talk about that a little bit. And then my overall goes is, we'll try to be interactive if we can. I have not mastered fighting stigma. If I had the secret sauce, I would have taught everybody by now. We all need to be in this together. And if y'all have better ideas or ways you go about it, things that work for you, that's fine. This is just kind of the way I do it and how I see in this very important area of advocating and fighting against stigma. All right, so what is stigma? So stigma is a noun, stigmata is plural. So it's a mark of disgrace or infamy, a stain or a reproach as on one's reputation, or a mental or physical mark that is characteristic of a defect or disease. So this is a nice quote. Stigma is a perceived negative attribute that causes someone to devalue or think less of the whole person. So kind of keep that in mind when we're talking about stigma and how it relates to SUD treatment in folks that struggle with it, and also sometimes stigma associated with treating people that have addiction. It's kind of ridiculous. So what's the prevalence of mental health and addiction in the US? Well, obviously it's very prevalent. So about 1 in 5 adults in the US experiences mental illness in a given year. That's a lot of people that struggle with it in various parts. As much as we tend to not talk about mental illness, mental health, substance use, a lot of people struggle with it. And it's kind of ridiculous that it's still, in some cases, on the fringes of society. So about 1 in 25 adults in the US, 11 million people, experiences a serious mental illness in a given year that substantially interferes with or limits one or major life events, their life activities. So significant, serious mental illness. We're talking like schizophrenia, bipolar disorder, major SUD that's flaring up. So a lot of people are affected. A lot of people are affected significantly. Among the 20, all right, so there's 20 million people at any given time in the US who experience a substance use disorder. About 50% of them actually have a co-occurring mental illness. You'll hear these numbers kind of vary, but the reality is there's a lot of overlap between substance use and mental illness. You treat one, you end up treating the other most of the time. So what's stigma in substance use? So it's real, it's prevalent. If you've been doing this for more than 5 minutes, then I'm sure you've run into some kind of stigma and how it's affected treatment. So there's lots of otherwise good clinicians who continue to view addiction as simply a bad habit or choice and not as a treatable neurologic disease the way we understand it. So there's lots of people that are doing their job and they do it pretty well, but they just can't get over that hurdle of addiction being a disease. The reality is when you view something as just simply a bad choice rather than a disease, it is going to change the way you approach both the treatment and the patient and arguably your colleagues too. So as clinicians who care for them, and hopefully we're all caring in different ways, but for those of us who do take care of folks with substance use disorders, our goal really should be, and I would argue our calling in a way or part of our job description is to try to decrease stigma and to use effective advocacy. So it's not just enough to treat people. You should be willing and ready to advocate for them. All right, so 4 domains of stigma, that's my family. The little one's a little bit bigger. You can see bigger pictures of her. So you have personal stigma. You can imagine what that is. You have medical stigma, stigma within the criminal justice system, and then also societal stigma. So there's different layers, there's different domains of stigma that really affects what we do. So personal stigma, this is a nice quote, but a subjective process that is characterized by negative feelings about self, maladaptive behavior, identity transformation, or stereotype endorsement resulting from an individual's experiences, perceptions, or anticipation of negative social reactions on the basis of a stigmatized social status or health condition. So people internalize stigma. So a lot of people who use have an enormous amount of guilt secondary to their substance use. So I always like to think of, when you hear, substance use, it's easy to go into like the us and them category. So, us being sober, them being addicts. It's weird when somebody's always held that kind of lifelong view and then they start struggling with substances, because now what does that mean? Does that make you one of them? Does that suddenly make you an outsider? So it's very easy for people to kind of slide into this real negative view of themselves, especially if they've already had that to begin with towards people that struggle. So a lot of people have a lot of guilt secondary to substance use. Shame is a common denominator that interferes with people seeking treatment. So if again, you kind of stigmatize it yourself and you kind of look down upon yourself, you're not worth it. You don't want to, you're not willing or able or want to get help. That really does interfere. So it kind of starts with the individual patient. We complain about kind of societal things and criminal justice, which we should. But at the end of the day, someone's got to choose whether they're going to seek treatment or stay in treatment or not. So personal stigma does get in the way of treatment. One way to combat it, one way that actually you could argue can make it worse, is people using labels on themselves. So, in medicine, we generally try to avoid using terms like junkie, alcoholic, someone's dirty, someone's clean. The argument is that can actually further stigmatize people. Certainly us doing it is bad. People doing it to themselves, that's kind of their call. I wouldn't tell somebody necessarily not to, like you're bad for saying that, but keep in mind that, keep always calling yourself, I'm dirty, I'm clean. There's certain connotations to that as well. So we certainly shouldn't be using it, but maybe it also reinforces their own personal stigma. All right, so medical system and the criminal justice system kind of lumped together, we call it structural stigma. So these are the rules, policies, and procedures of institutions that restricts the rights and opportunities for members of stigmatized groups. So we certainly see this. So if you've spent any time in the hospital or a clinic and you see how suddenly someone gets treated a lot differently if there's any even hint of a substance use disorder. So, classic case, someone comes in with pain, to the ED, and normally they get treated. Oh yeah, how's your pain? Here's some medicines, blah blah blah. If you superimpose that, suddenly some nurse says, well, I heard they use drugs. They're going to get treated a lot differently. Maybe rightfully so in some ways. You want to be more careful, but it's not unheard of to have nurses going in, yelling at people, saying things. People get treated differently when they have addiction. You will certainly see legislative actions that are meant to exclude or limit the scope of substance use treatment. So that's something we're dealing with now. We do have this moratorium on methadone that still exists. Methadone is still extremely difficult to prescribe and can only be through an OTP, which has not changed in 50 years. So some things to consider. Laws like if a EMS worker encounters somebody on fentanyl and the EMS worker overdoses by touching it, which is impossible, by the way, that person is now charged with a felony, things like that. So, all right. So it's not uncommon, unfortunately, for hospitalized patients to be lambasted by staff regarding their substance use history. This is especially common if anybody's ever worked in obstetrics. That can be a really rough area for folks. You hear some horror stories. And I have certainly heard patients, including recently, say, I just don't want the hassle of being on medicine because I know that some nurse is going to yell at me or CPS is going to come in and try to take away my kids because of me taking the medicine that you prescribe. So keep that in mind. What about societal stigma? So this is the phenomenon of large social groups endorsing stereotypes about and acting against a stigmatized group. So, kind of picking on people. Oops, 1 second here. I don't know what I did. Exit. Sorry. Okay. For substance users, societal stigma is deeply, deeply entrenched in the culture. So again, this idea of kind of us and them, us being sober folks and them being folks that struggle with addiction. One of the common things you'll hear when it comes to, say there's a rehab going up or a methadone program or even a Suboxone clinic, we want them to get help, but not here in my town. It's okay. We want the poor addicts to get help, but not here, not where I live. I don't want my kids seeing that, or I don't want a bunch of drug dealers around my house. They should get help, but not here. So that's, a common thing you'll hear in society and something we've had to fight against in the past. Often there's a lot of misinformation out there. I mean, a lot of the perception that people have in society is based on very old ideas of addiction treatment. Some of them still hold true, but some of them are quite frankly outdated and don't take into account the seriousness of the disease or, how much things have changed, how much treatment has changed, how there actually is treatment now when there wasn't always. There have been some, as much as there's been some bad things, there have been some legislative changes have been made to combat stigma in a positive way. And, some things that have been kind of discovered through case law, like we'll talk about later if we have a little bit of time, but hopefully, society does have a way of changing and ideas have a way of changing over time. And I would say in the pandemic, a lot of people have struggled with depression, anxiety, and substance use has certainly taken off. I think people are shining more light on the fact that mental illness, substance use is a real thing and anybody can struggle with it. And hopefully that has maybe destigmatized it a little bit from a societal level, but we still have a long way to go. All right, so stigma is a real problem. There's different layers of it, the onion of stigma. Advocacy is one way to decrease stigma. So how do you use advocacy? So again, I would argue it's a core component of what we do, especially, if you want to be an effective healer, you have to advocate for your patients at the various levels. There are certainly opportunities available to advocate, not only for our patients, but also considering treatment of, the field as a whole. Because again, not everybody is down with treatment in any way, shape, or form. There are people that would argue that if someone is addicted to drugs, let them die. Don't Narcan somebody for the third time. Don't Narcan them for the first time. Don't let people go to rehab. There are insurances that will not pay for people to go to rehab. There are government insurances that will not pay for people to go to rehab or, get on medication. So We need to advocate for our patients. We also sometimes need to advocate for ourselves in good treatment. So when you're advocating, you can advocate at the various levels. It doesn't have to be, it's hard to advocate for all at the same time. So from a personal stigma level, just talking to people individually, it's amazing how much disinformation is out there. And once you actually have a chance to sit down and explain to someone, why we use medicines, why we don't recommend forced detoxes and things, talking to patients, talking to their families, explaining it as a disease, that can go a long way, just hearing it from somebody that they realize has their best interest at heart. Medical stigma. So, working on the old guard that exists, and, frankly, some of the old guard might have to die off over time for it to ever fully change. But, working on the people that already exist, and, some of the ones that are maybe still entrenched in their crazy beliefs against it, and also trying to teach the next generation of physicians and nurses and PAs and social workers about treatment. So the criminal justice system, meeting with judges, CPS, police, legislators, training. Police academies have no training in substance use. The only training they have is that any treatment is bad. That's basically what they're taught in police academies, like the State Police Academy. Societal stigma. So, disseminating information to the public, working on these legislative changes, they can help decrease societal stigma. So again, one area of medical, is medical stigma. So, this is kind of an interesting review that was done a few years back, but this is about graduate training. So people that are coming up through the ranks, and, what do we teach them? So conceptions of health advocacy have evolved towards advocating with rather than for patients, communities, and populations. So the idea is you try to get people involved in their care. So who better than someone that's dealt with these problems than to advocate on their own behalf? So that's kind of one area that you can help advocate. Teaching people, so longitudinally, a curriculum less common. Unfortunately, it doesn't tend to be something that's taught all throughout school, but it should be, and it appears to be very promising. So teaching people at a young stage in their career as they progress, and continuing to do things like this, and it helps people stay engaged and realize how the field changes. Not something static that you learn 1 year in medical school. Hands-on immersive opportunities build competence and confidence. This is kind of something that we help do with ECHO. Right. So if you don't have maybe all the hands-on training yourself, you can learn from other people that do, and over time build up your own competence. Community identified needs and partnerships are increasingly considered in designing curriculum. So this is always great if you can get community buy-in, if you can see, what mainly is your community struggling with. Obviously, we have a major opioid problem. Methamphetamines is getting completely out of control. Those are things that the community could identify that, that maybe we could work with, or other things, finding people jobs, folks that get through treatment, but have some legal history, trying to find jobs for people in recovery. All right. Lastly, resident-led and motivated programs appear to engage residents and allow for achievement of stated outcomes. So again, this is specifically for graduate training, so medical school, but this really can go for any type of program. So if students themselves, if learners are wanting to lead this stuff and motivated, of course they're going to engage more. So engaging people in the recovery community, having students kind of run it themselves, it can be wonderful. But again, trying to intervene early and teaching people early in their careers how to best treat this kind of stuff. All right. So these are two cases of situations that arose when I was in training, and I'll kind of go through them fairly quickly-ish, and representing some stigma in substance use treatment and just how I reacted. And you can judge me right or wrong if I did the right thing. So the first case is I used to work at I used to moonlight at Valley's crisis unit. So we had this young lady who showed up for heroin detox and treatment. And the ironic thing was I wasn't even the guy moonlighting there. It was one of my colleagues. Anyways, this poor lady had been struggling for 5+ years with opioids. She was never on any kind of medication, so never been offered medicine, never stayed on medicine, a lot of stigma towards it, obviously. So anyways, the big thing with this case was, so this lady wants treatment, but she has drug court. So she's in drug court due to legal issues that are, of course, related to her substance use. So this young lady, no treatment, in drug court, on detox unit, getting help. So we got her off of opioids because we weren't allowed to use bup at the crisis unit. So we weren't permitted to. We could get people off of opioids and then get them into, say, a Suboxone program or switch them to Vivitrol. So we could do those things, but we couldn't do them specifically there. So she was wanting to go to a 28-day program, which is great. She was very interested in long-acting injectable naltrexone, i.e. Vivitrol. So she's not even trying to get on Suboxone. She's not trying to get on methadone. She's trying to get on Vivitrol, okay? However, her local drug court refused to allow her to be placed on naltrexone. So the drug court itself said, we don't want this lady on naltrexone. And this is literally what the quote was per staff report. They want her to have cravings to use. So they wanted her to prove that she was serious about her opioid addiction. So not only were they against methadone, not only buprenorphine, they didn't even want this poor girl to be on naltrexone, which she's begging to do. So the drug court is flat out refusing to allow us to put her on naltrexone. So I wasn't involved in this initially. So I was kind of sitting in my office minding my own business as chief. And then one of the other residents told me what was going on. And I, what did I think? I was like, what? I completely lost it. I was so upset when I heard that, because again, I could understand maybe a little bit, okay, no methadone, maybe no Suboxone, but no Vivitrol, not even naltrexone. You can't even let me give this poor girl naltrexone. So I got involved, of course, real quick. And these were the options that I had. So one was to do nothing. So basically, you could accept that the drug court does not permit naltrexone or any other use of MOUD. So just accept it, live with it. You can't change it. You can't fight City Hall. Just ignore things. So that was one option. Second option was to get very upset, lash out at their foolhardy approach to treatment, which was very tempting for me. So I wanted to call them and just up and down MF them or say whatever, because it was ridiculous. I mean, I could not see any valid medical reason, outside of just stigma-induced hysteria, to not permit this person to even be on naltrexone. So that was my second option. I didn't take it. The third option was, I was like, you know what, maybe I should try to educate them. And so I called the lady and I just explained the situation. And, we talked for like an hour. It was the lady who ran the drug court. And eventually she actually offered for me to go and do a presentation. So present to the drug court, which is pretty neat. So this was one of the first presentations. I kind of walked into this by accident. So this was 3.5 years ago, almost 4 years ago. So I was still I was a resident. So anyways, so what did I teach them about? I taught them about addiction being a brain disease, something that we know very well. So it's a brain disease, the ABCDEs of addiction being a brain disease, how addiction lies in kind of the lower parts of the brain, the parts we don't have a lot of control over. You put somebody's brain in an MRI and it changes a lot from the time they start using to when they, before they started and then when they're actively using. It's amazing. Talked about it being, a disease that people have relapses, they have remissions, so people get better, people get worse, and how it's often progressive and fatal. So people die of this disease. People die of addiction. We've seen it all too often in the last 2 years of COVID. The idea of containing versus curing. It's a nice idea to think that we can fully cure addiction. We're probably giving ourselves a little too much credit saying that we can, but we can certainly contain it, just like many other diseases that we treat in medicine. And then, of course, what are our goals really as providers is one, to keep our people alive. So we cannot treat dead people, right? So we want to keep our patients alive. And then if they're going to stay alive, let's give them some of their life back that they've lost as a result of addiction. So that's, that was part of what I taught them. And that actually went over pretty well. I spent about 3 hours in a courtroom. It wasn't in the middle of court, but like after court. So I'm hanging out in the Preston County courthouse and just talking to everybody in the drug court for like 3 hours. It was pretty interesting. One of the things, these are some questions I like to pose to medical students, and I think Dr. Zhang stole these questions. Well, I let him steal them, but when advocating about addiction being a disease, these are some questions I like to pose to people. So one is, what is the closest non-romantic connection two people can ever have? So for my money, it would be parent-child, specifically like a mother and a child. We just had Mother's Day yesterday. So the very fabric of society is the family, you could argue. Question number 2. What other disease leads people to choose to continue to use something over having their children? So the idea that addiction is so powerful that it can literally tear away the fabric of society, the family, it can go in and separate, mother from children, children from parents, spouses from each other. So addiction has that kind of power over the human brain, that it can go in and divide up society, slice and dice it. That's pretty scary when you think about it. And last question, if we're on the parent side, so who in their right mind would ever choose a substance over their child? The answer being they're not in their right mind. Folks are not thinking, their brains are not normal when we have the disease. Just like someone who's had a stroke or Alzheimer's is not exactly acting the way they once were. That's kind of the way you need to think about it when you're treating addiction. So sometimes asking those questions can kind of help people open up and realize the seriousness of this disease. All right. So a little bit more in OUD. I'll go through this fast wall of text. You're not supposed to do this in presentations, but OUD is a chronic relapsing disease which has significant economic, personal, and public health consequences. I think we all can agree with that. ASAM defines addiction as a primary chronic disease of brain reward, motivation, memory, and related circuitry. So it's a brain disease. Dysfunction in these circuits being reflected in an individual pathologically pursuing reward and or relief by substance use and other behaviors. We'll skip down. ASAM views addiction as a fundamental neurological disorder. Again, fundamental neurological disorder, thinking more along the lines of Alzheimer's, Parkinson's, stroke. So fundamental neurological disorder of brain reward, motivation, memory, and related circuitry. And recognizing is that there are unifying features in all cases of addiction. So there's similarities between opioid addiction, alcohol addiction, gambling addiction, sex addiction. It's all there, including substance-related and non-substance related addiction. So again, it's a brain disease. There's parts of the brain that are affected. There's certain neurotransmitters, specifically dopamine, that tends to be the culprit, the bad guy, but it's a brain disease. It's a neurologic disease. So what are the opioid treatment options? Again, something that I'm trying to teach the drug court. So the one option, and this is something that that folks will advocate for, unfortunately. No one that has ever had family who use, I assume, but one option is to do nothing and let them die. So again, if you stumble across somebody for their third overdose of the week, just stand back and watch them go. Obviously, that is not ethical. Physicians, clinicians, folks who treat people who use substances, I don't think anybody here would advocate for that. I hope not. If you're going to advocate for something, advocate for good, not for bad. So it's one option. The other option, and this is historically what we would do, is we would just detox them. So send them to detox. That sounds like a wonderful idea to treat opioid addiction, but it doesn't work. The reality is the relapse rate is incredibly high. So much so that ASAM does not even consider detox to be a medical treatment of opioid use disorder. So I'm sorry to say, if anybody here still practices purely opioid detox without any kind of medicine or recommends it, that is not treatment. That's, I would argue, malpractice to do that. So it's not ethical to say just detox them, no medicines. Now, if people choose they don't want to take medicine, you're not going to force someone to take medicine, but they should know that it's basically playing Russian roulette with 19 bullets and a 20 bullet gun. So you're just asking for something bad to happen. So what about if you send somebody to detox in a 28-day program? 28-day program cures addiction, doesn't it? It sometimes works. you know, it's not terrible. It doesn't maybe hurt anything in a way, but it's not a guarantee of success, that's for sure. And you know, you will hear rehab saying they have 98% recovery rate, and that's never true. You know, if you treat, say, 100 people and you send out 100 surveys and only 5 return your survey and 4 of them say they're doing okay and 1 says they failed, you know, God knows what happened to the other 95 people. So rehab, not necessarily a bad thing, but by itself for opioids, it doesn't really do the trick. What about using medicines? Well, it usually works. Not always, but usually. What does that mean? About 50% of people do really well on it. They don't really relapse. They just take their medicines and they live their lives. And that's not a bad rate of return, that about half the people you treat on medicines do well with it. And actually a large percentage of people actually stay in treatment, even if they're not, you know, doing great. Maybe they're still struggling with other drugs and things, but at least they're in treatment, they're alive. And that's something. So that's why we use medicines. I mean, it's plain and simple. So what about MAT? You know, you guys all know this, but lots of people have an opioid use disorder. Most people don't receive treatment. It's safe, it's effective, really at decreasing the frequency and quantity of opioid use and reducing the risk of overdose and death. Specifically, in terms of risk of overdose and death, really methadone and buprenorphine, that's what they help out with. Now, Trexone's not as good with overdose prevention. So it's got a ton of evidence, but of course, it is highly underutilized and highly stigmatized. Again, what we're combating today. So there's lots of people that need it. Unfortunately, not a lot of people that get it. All right, so it is the gold standard. Keep this in mind if anybody argues elsewise to you. It is always the gold standard of treatment for opioid use disorder. Detox, rehab is not the gold standard, I'm sorry to say. Every professional addiction society recommends using medications. So that's everybody, ASAM, AAAP, SAMHSA, AMA. Everybody who's anybody who does this recommends using medicine. It's called the gold standard in the Surgeon General's report. Keep in mind, this is the only effective and arguably the only ethical medical treatments available for OUD. So if you are trying to treat OUD and you're, say, a physician, if you are not offering medicines, you are not offering standard of care. All right, so what are the 3 medicines? Of course, we have methadone, we have naltrexone, we have buprenorphine. They're all a little different. And again, keep in mind, the goals of treatment are: 1 is to decrease mortality and reduce morbidity. So less people dying, less people suffering, and then increase their quality of life. We overcomplicate things. So this is a nice way I like to compare addiction to another disease. So you compare OUD to, say, lung cancer, general lung cancer. So you always have to start with exposure. So people that have never taken an opioid before are not going to be, you know, addicted to them. Typically lung cancer, you know, you have some kind of environmental exposure. Often, you know, tobacco tends to be it, but there are other forms of lung cancer that there are other things in the, you know, things that can cause it to develop. So opioid use disorder takes a while to develop. So people don't go from not using at all to suddenly raging opioid addiction. So it takes a while to develop the dependency. And actually, that's the same way cancer is. You know, you start out with, you know, one cancerous cell, and it's not like immediately you go from one cell to metastatic cancer all throughout your body. So it takes a while for it to really creep up on you. Of course, if you don't treat OUD, people are going to die. Lots of people are going to die. So you're going to have overdoses. You're going to have endocarditis. You're going to have hepatitis C. You're going to have people killing one another, you know, to get drugs. It is a fatal disease. Of course, if you don't treat lung cancer, people are going to die from it. And sometimes they even die from the treatment. Treatment's not perfect. Can you treat OUD with medicines? Absolutely. Absolutely, you can. Can you treat lung cancer? Of course. And, you know, sometimes I compare, like, detox is almost like surgery, and rehab maybe is like radiation, and then medications is like chemotherapy for somebody who has cancer. So it's not all that different the way we approach this. So again, about 50% of people get better on MAT or MOUD or whatever we're calling it these days. About 50% of people, if you catch it early enough, lung cancer is fairly treatable. again, we like to pretend we're better than we are, but people, even with our best efforts, people will still struggle and die. And that's the reality with medications. You could be doing all the right things. People are still going to struggle and die of their disease, but at least you're helping a lot more than if you, did what we used to do. All right. So is there a lot of stigma? You better believe it. We've been talking about it. And sometimes, which I think is kind of ludicrous, is there's more stigma with the treatment of the disease than the disease itself. Just think about that for a minute. So just, there's more stigma with somebody treating a disease, the medicine used to alleviate a disease, than the disease itself. There's not a lot of stigma with getting cancer treatment anymore. However, it's kind of interesting for those who are interested in medical history. It wasn't all that long ago that people wouldn't seek treatment for cancer. And there are still parts of the state and of this world where if someone has cancer, they don't tell anybody until it's too late. They kind of hide it and keep it secret because they're ashamed of it, or they don't think there's treatment available. So one of my hopes is that the more that people understand the disease, understand how to treat opioid use disorder, the more people it's going to become more and more mainstream, similar to the way oncology has become with cancer treatment. All right, so a little bit. So I did all this drug court training stuff after almost losing it on them. And what was the results of it? So they went to the 20-day program, and they actually allowed them to receive the naltrexone at the end of it. Thank goodness. And she completed the program. So some of the misconceptions were corrected, including that addiction went away after 6 months. So this was one of the judge's previous expert opinions. I don't know who in the world it was, but they said some expert told them that addiction resolved after 6 months. That was the evidence for it. Okay. And then lastly, the drug court and I left on good terms. So that was encouraging. So nobody's feelings were hurt, and they occasionally will even call me and ask me about stuff. So, all right. So the second case of stigma was a little shorter. The second case, this was an older guy who, again, was at Valley. Everything interesting happened at Valley when I was doing this. This is about a year later. This guy had been using pain pills for many years, secondary to lots of chronic pain, which unfortunately, that's what a lot of our folks, how they originally got into it. So he was arrested with an intent to distribute, been sentenced to 18 months in a local drug court, another drug court. It was actually the same drug court too, which is kind of interesting. So he'd actually been taking methadone off the streets, which when we'll get into that, that's pretty rare for people to be taking methadone illicitly, unless it's prescribed for pain. Methadone from an OTP, opioid treatment program, is rarely diverted. But this guy had been on methadone for a few years and was recently started on bupe by actually one of the physicians here at the CONT clinic. So, good clinic, good doctor, everything was legit above the boards. But unfortunately, the drug court did not want him to remain on bupe, and they demanded inpatient detox plus or minus a 28-day program. So you're seeing a trend here. So non-physicians, judges, drug court people making medical decisions about people. So the drug court demanded they came off bupe, but they were okay this time, thankfully, after our talk that we had with him being placed on long-acting naltrexone. So they're much more amenable to medical treatment plans, much more open about it, much less demanding. And, we were able to put him on an SNRI for some of the pain, and we got him off bupe. Was it ideal? No, at the time, but he was able to get on naltrexone. And as of last time I checked, which was a couple years ago, he was still sober on naltrexone. So, it wasn't perfect, but it was better than nothing, which nothing is what initially in that first case they wanted. It was absolutely nothing for this person. So some lessons in the criminal justice system, if you've had run-ins with them in various degrees, keep in mind that people in criminal justice are taught to see things very much in black and white. So there's not a whole lot of gray when it comes to court, to the legal system. There are some judges that honestly believe there is no utility to using buprenorphine ever, never, ever, ever. And a lot of times I think this is colored by negative anecdotal experiences. And I would argue a lot of it comes from antisocial patients that they've seen. So people that are true sociopaths. So not just people that are using drugs, but people that are selling drugs that have killed lots of people. Okay. People that have done some horrible things. So they aren't seeing so much the folks that are in COT or in one of y'all's programs and doing well and has their family and working and all that stuff. They're seeing some bad examples. So it's just natural as a human being that that's what you associate treatment with badness. Some judges, some people in the courts, some police officers immediately believe that you're impaired if you're taking bupe. We've had instances where folks get DUIs because they're taking their prescribed medicine, and that, of course, should not happen, and something you can advocate against. Keep in mind that addiction training is woefully inadequate, so they do not go to school for this stuff. Again, in training in, say, police academy, there is no addiction expert that comes by and tells them how it is. Probably 1 or 2 hours of lecture could largely change the way they view this stuff. And I will say that if someone is just completely, diametrically opposed to MET, it is pretty hard to confront them and sort of, change their mind about it. I've tried many a times, and judges are rather opinionated, so they're very judgy. Imagine that. It's a dad joke. All right. So how do you combat stigma through advocacy? So one way is you try to correct misinformation. So if there's something obviously super misinformed, you can tell them about it. Just say, well, I don't know about all that. I think it might be maybe a little different than you think. Not everybody that takes Suboxone is bad. In fact, doctors can take Suboxone and practice medicine. Imagine that. Stick with the evidence. So addiction is a disease like any other, and treatment does work. So people get better that are in treatment. People that are not in treatment die. Try to engage people in their own advocacy. So if you do have examples of people that have done well in your clinic and something's going on, maybe ask them if they want to help. Let people advocate for themselves. Get real life examples. Peer recovery coaches are great for that. Again, try to avoid using the addiction labels that exist. Use the alternatives, more medically appropriate ones that can help. This was one I used to be guilty of. Do not put stigmatizing images in presentations. So, pictures of people overdosing and needles and things like that. It might get you a headline somewhere, get people excitable, but it's not really doing anything good for anyone. Being assertive in your advocacy efforts. So I think it's really easy to sort of be meek about this stuff and not want to cause waves and get people upset with you, and that's all well and good, but sometimes you do have to assert yourself and stand up for what's right. I would say always be prepared to advocate. So you never know when it's going to come up, whether it's in talking to a colleague or maybe being down in the state capitol and meeting about something else. Things happen, or talking to a patient individually. So always be prepared to be an advocate. All right, so a little quote on silence. This is a nice quote I found. So all too often when we see injustices, both great and small, we think that's terrible, but we do nothing. We say nothing. We let other people fight their own battles. We remain silent because silence is easier. I'm not going to pronounce this because I hate Latin, but this Latin word means silence gives consent. When we say nothing, when we do nothing, we are consenting to these trespasses against us. So you can't silently advocate for your patients or yourself. If you hear some nonsense, you can't keep your mouth shut and just think it'll go away. So you do have to speak up, which is uncomfortable, but it's a fight worth having. So, if you're going to advocate for something that saves people's lives. It is kind of the right thing to do. And certainly addiction treatment does that. All right, so in summary, SUDs are extremely common, as is the stigma towards them and treating them. It's a disorder of the brain reward pathways, not just bad choices. Domains of stigma include these various ones, but personal, medical, criminal justice, societal. It often does interfere with treatment, as kind of the examples that I told you. treatments that would otherwise be effective. As healthcare professionals, one of our responsibilities, one of our job descriptions is to be advocates and use your own advocacy to combat the stigma you see daily. So again, whether it's something small like talking to a patient, which is not small at all, believe me, or knowing a state legislator or something, you can make a difference. And avoid letting any stigma in any form prevent you from providing excellent care to patients struggling with the horrible disease of addiction. All right. So we could stop and do questions, or I could give you all a quick update. And I know it's already 4:55, so but I could give you a quick update about something that's kind of interesting going on. So I think it's interesting. So I think there's probably questions.
Thank you so much, Dr. Husa. First and foremost, thank you. That was really important information. Such a powerful quote that you ended on as well. And I appreciate you sharing your personal cases that you went through as well. That's very powerful as well. So I think it would be great for you to give the update personally. Everyone chat in as well what you think or chime in. I did want to just mention a couple things that were going on in the chat. I think Tanya mentioned, she was just commenting saying that CPS also uses their own biases or misconceptions about MAT programs.
Absolutely.
And then she also mentioned it's important to sit on drug court's multidisciplinary team. And she said she thinks they still have those for drug court.
Yeah.
Let's see.
I know the drug court that I spoke at, they didn't have a single physician or nurse practitioner or anybody on it. So they had no help whatsoever, which was kind of, again, interesting.
Frustrating, absolutely. But yeah, definitely the update I think would be awesome.
All right, so this was the U.S. Department of Justice. So this guidance on protection for people with opioid use disorder under the Americans with Disabilities Act. So Americans with Disability Act is a pretty big deal, right? Because if you violate it, you can get in some serious trouble. So this was actually a thing that came out. So opioid crisis poses an extraordinary challenge to communities throughout our country. The DOJ has responded with a comprehensive approach prioritizing prevention, enforcement, and treatment. This includes enforcing the ADA, which prohibits discrimination against people in recovery from OUD who are not engaging in illegal drug use, including those who are taking legally prescribed medication to treat their OUD. Provides information how the ADA can protect individuals with OUD from discrimination, important part of combating the opioid epidemic across American communities. All right, so this is pretty interesting. So basically, this is the Department of Justice on high putting down these recommendations. So some of them. So does the ADA protect individuals who are taking legally prescribed medication? So yes. So if a treatment facility or somebody tells you they can't take MOUD, technically they're in violation of their ADA rights. So it uses an example here like a sniff, refusing to admit somebody with OUD, which happens all the time because they're on MOUD. So this is actually a violation of the ADA. Okay, so they could get in serious problems. Or a jail, we've mentioned it. Jail does not allow inmates to continue MOUD. Blanket policies prohibiting MOUD like North Central violates the ADA. So this is something that's been going around in our other ECHO group with judges, but this is now policy that's taking place. Some more. Does it protect people who are illegally using opioids? In short, no. So if somebody is misusing, say, getting Suboxone on the street or misusing other drugs, they don't fall under the umbrella of the ADA protection. So it's real important to let people know that if you want the protections, if you want to stay on your medicine, you basically have to stay adherent to your medicines, and that's it. Yes, so some different things. Individual ADA protect discrimination based on their association with individuals who have opioid use disorder. So even, somebody who's being discriminated against because they have a friend or colleague or whatever, you can't do that. Or, if employer sees somebody's on OUD treatment, technically you can't prohibit somebody from working unless it's like a safety concern, like true safety concern, just based on them having addiction treatment. So it's pretty interesting. Can you have a drug policy? Yeah, you can have that. But you can't actually report any kind of discriminatory actions that happen. So I think this could be a real game changer. Again, I think of as my kids. I don't want, when they're older, I don't want them to, if they had a problem, that they wouldn't be able to seek treatment, or be prohibited from receiving it, and whatever whatever thing they might be doing. So hopefully this is actually a major thing that can actually help us going forward. So keep this in mind. This was just released about a month ago. So it's going to take a while for individual places to sort of adhere to this, but if a jail is discriminating against it, that is actually unconstitutional. So just keep that in mind. So if you're advocating now, you have a little bit more ammunition in your belt. So hopefully that was helpful.
Jeremy, I just wanted to share something real quick.
Yeah.
We have a patient in our CONT clinic who's been doing really well for several months on Suboxone. He is going to federal prison beginning of June, and was told by his lawyer that he had to stop his Suboxone. And I reached out to you and took your advice, and we have contacted our case manager contacted the prison, and
Yeah.
they are now allowing him to stay on his prescribed Suboxone.
Nice. All right. Perfect. That's great. Yeah, I think the lawyer was just taking the easy way out. I think that's specifically what they said, but that's great. That's great. And that needs to happen at state level too. And once we crack that nut, that's going to be a difficult nut to crack, but we'll get there. So that's cool. Anybody else have anything? Sorry, we went over time here, ladies and gentlemen.
No apologies at all. Jeremy, sorry about that.
Yeah, just share one thing real quick. A recent victory that we had combating stigma here in the northern panhandle is the CPS. It's not the criminal justice system, but the family court system had a stigma or misinformation about they wouldn't allow the participants who tested positive for fentanyl to have supervised visits with their children because they were under the impression that if they tested positive for fentanyl and then somehow touched the kids, that they would transfer fentanyl to the kids and cause an overdose. So luckily, we were able to intervene in that and change the ruling that had been longstanding for a long time. So that's recently happening here. So we changed it. That it does happen, and it's still happening now. So
yeah.
Thank you for sharing that. We also had a question in the chat asking, does this count as a disability that will help the individual use vocational rehab programs?
I have no idea. I would hope so. I mean, there are some vocational stuff, but I mean, at least as long as it's being counted as a disability in any way, which is a big win, honestly. But I'm not sure about that. I assume that there should be, and there are programs that help people that are recovering.
I'll speak up on that. I just had a patient that I referred to Division of Rehab for vocational placement and training, and he got accepted. He does have another disability as well, but the substance diagnosis counted as one of his disabilities to make him eligible.
Wonderful.
Yeah, I was real excited.
That's good. That's cool. It's good to hear this because we always hear about the roadblocks that we face, but the reality is there are things changing and for the better that in every day, and it's nice to share that with each other. So anybody else have anything?
This is Tom Menigan, a pharmacist. I won't claim to be a clinician, but I care deeply, and I am still a founder and part owner of a pharmacy practice that specializes in taking care of folks in recovery. And we and pharmacies all over the country are challenged with access to buprenorphine and Suboxone by wholesalers who set ratios as to how many controlled substances we can order. And if a pharmacy orders more buprenorphine or Suboxone, it raises their ratio, and wholesalers may cut off their controlled substance access. And I could argue, and we could go on for hours about the challenges of that as discriminatory. I just want to put it out there, and we can talk more later, but there's a clear stigma among pharmacies not to stock these meds because they change their ratios and can challenge their relationship with their wholesalers.
Yeah, we've heard similar things. It'd be nice to have like a wholesaler that just specialized in this and didn't have those arbitrary numbers or anything. I wonder if anybody's thought about going above the wholesaler's head or reporting them maybe to the ADA for violation. So yeah, it's interesting. Thanks for that.
This has been so wonderful. I did want to say a final really sweet comment we got in the chat from Elizabeth saying this has been one of the best presentations she's seen on stigma. So thank you. Any final comments, questions from the group? And as always, if there are any items or questions that come up later on, you're welcome to email myself or Elizabeth, and we'll make sure to get them addressed for you all. All right, thank you so much, Dr. Husted. This was awesome. We really appreciate you. It's been really great discussion as well. So I'm glad we were able to squeeze some discussion in at the end here. My only announcement is that the next session will be on May 23rd, and Phil West will be presenting on confidentiality. So keep an eye out for that reminder, and we'll see you all next time. Thanks, guys. Have a good evening.
Thank you. Bye, everyone.
Bye.